Now it is. Y'all are good to go. Yes, I think Whitney was actually listening to hear when we actually started to record it. So just to start out with, for developmental peds, we actually don't get any of our own content outlines. So we're not a section. Awesome, right? So instead, what we do is kind of scattered amongst all the other specialties. So it makes it a little bit harder for y'all to study for our portion. But that's just because it's kind of integrated into a whole bunch of places. So I put the Gen Peds content outline on here just so you could kind of see where we're pulling it from there. So I encourage y'all not to be like me, who figured out there was a course content outline to your exam like 3 weeks before I took boards. It's good to know that exists now and know that they only test you on the things on that list to help you kind of refine your studying. So a lot of what we do in Gen Peds actually falls under preventative care and well child care. So a lot of the stuff that you guys are responsible for in terms of questions actually come from there for us. And then some of it's coming from like the mental and behavioral health part, but there's also a lot of psychiatry in there. So it's kind of a mixed bag. So now we have some questions. I only have like 15 questions or something like that, because I actually think that oftentimes it's more helpful to actually go through the question and talk about it than to just like slam as many questions into you guys as I can come up with. So we'll start with these. So this is, I'm trying to give you guys kind of some examples of how they test developmental peds stuff. So you guys kind of know when you read the STEM, like, oh, I know what this question is, because they love to hide developmental peds questions in what makes you think that you're going in a different direction. And then you're like, oh, wait, this is just a milestone question, jerks. So this is one of those. So they start off with like this lovely well child check where a kid walks into the room and you're just glazing over all this information because you're like, yeah, where's the real question? Well, the question is, these are all milestones that they're going to ask you how old this kid is. And so whenever you get one of these questions where you lead into it and you're like, they're just giving you weird description about a kid walking into the room and they're holding a ball and 2 crayons and they lean down and scoop up some blocks and it's like rambling. That's always a milestones question. That's what they always look like. And all you really need to know is which milestone are these. So to pick it out, he points to a box of crayons. So he points. And he draws a vertical line and a cross. He draws a person by making 2 circles. That's a 2-part human. And stops drawing and says, look at me, and balances on his foot for 3 seconds. And he says, look at me, which is a sentence. So those are all your milestones that they gave you. And they gave you young ones and old ones, and they want to know how old this kid is. So they're really looking for what's the oldest milestone that this kid can do. Is really their question. And then they want to know, that would be the development that's most typical for what age? 4. Exactly. So yeah, the cross was really the giveaway, oddly, and the balancing on 1 foot. Everything else was of a much younger child. So this is like a really good example of a sneaky milestone question. They also didn't give you good language. My trick for these questions, I picked this one on purpose because my trick for these is that the language milestone is usually the answer, because they really like to push language milestones on y'all. And so if like a worst case scenario, you're like, I have no idea how old this kid is, but then they have a really good language example, just go with the age of the language example. But in this one, they use this like little pokey 3-word sentence as the only thing the kid says. And so that's like a 2.5-year-old, 2.5, 3-year-old. So that didn't help you. So this was a tricky one, but you guys did it great. I have another one, and then I'll ask you questions about milestone questions. So here's another one of these meandering. He walks into the exam room. It sounds like the beginning of a bad joke. And then he's holding the ball. He's going to roll it back and forth. He can throw it, but not catch it. He tries to catch it, almost falls over. He squats though to pick it up. You offer him a crayon and a piece of paper, and he can do a straight line. He shows the paper to his mom and smiles at her. And then he stacks 2 blocks. How old is he? He's 2. Yeah, he's 2. He's 24 months. This also just is a little fun example. They secretly have coded that this kid does not have autism. They did this intentionally. And so this would be a STEM that you could very easily see going in an autism direction, because it's a 2-year-old milestone. And what social things did you see in this that let you know they very emphatically told you this kid doesn't have autism? How did they do that? Yeah, and shows the paper. He shows the paper and smiles. So like in terms of like test strategy, this was them almost like outright saying this child does not have autism. So those are the kinds of things that you want to be looking for in the 2-year-old milestone set. So if you see them say something like doesn't make eye contact or doesn't show it to mom or doesn't smile at anybody, they're trying very hard to make you think about autism. So we'll see some of those. This was just a nice setup for that. Any questions about milestone questions in general, how those get presented, how they annoy everybody because you just have to memorize the charts? Okay. Every so often they'll be really sneaky with milestone questions, and they will give you a child who has developmental delay. They will tell you the age of the child. They'll say like, this is a 3-year-old. Then they're going to give you a set of milestones that are not 3-year-old milestones. And then they will say some very nice thing like, so which handout do you give the family? And they'll have the ages down there of the developmentally delayed milestones. And one of the answers will be the 3-year-old handout. And you never give the 3-year-old handout to a kid with developmental delays. So if they said this kid is 5 and then they gave you all these milestones, you would give them the 2-year-old handout, not the 5-year-old handout. It's just a milestone question, but it throws everybody when they do it. And they do it with some regularity. So watch out for those too. Not nice, huh? Okay, now I'm just going to hit a few kind of high yield topics. Things that we sometimes hit on developmental peds, but if you didn't get the right kids on your rotation, you may not have heard about. So I want to make sure you hear about them at least a few times. So this is one of those. So you've got 9-month-old twins. They're very behaviorally different. The boy whimpers when he's hungry and the girl screams. The boy plays quietly during diaper changes and his sister is moving all the time. And she tends to show her emotions with strong intensity and the boy's real easygoing. So what's of the following the best response is? Temperaments, excellent. So what do you guys know about temperament? Yeah, there's born with it, exactly. Anything else that you guys know about temperament? We don't talk about it a whole ton because we mostly see kids who have diagnoses in developmental peds, and we tend to be the people who talk about temperament. But temperament is not a diagnosis, it's just the way you're hardwired to be. So in gen peds, you see temperament differences all the time. So the kids lots of times have different temperament. This is why when parents will come in and say about a totally neurotypical kid, I think this kid has ADHD because he's not like his 2 older sisters. And now you're trying to explain to them why she does not have, or he does not have ADHD. He's just not like his 2 older sisters. So temperament is what explains that. And if you're in practice and you're having trouble convincing people that temperament is something that's real, the AAP actually has tons of handouts about temperament. You can just Google like AAP temperament and they have like nice 1-page handouts that talk to parents about temperament and you can be like, see, it's a real thing. And so they love to ask about this. First of all, because I think anytime the AAP has lots of good information about something, it seems to also pop up on the board exams. They're like linked. And then it's just something that parents ask about a whole bunch. So it's a good thing to know about, but they love to ask about it on boards. Is there a reason why any of these other responses are just terribly wrong? Any of these have advice that you think I would never give? Yeah, because she sounds pretty common, like she sounds pretty typical, right? Do you think that they need to go to behavioral counseling? Yeah, so there actually are some, the only reason I highlight that one too is just that there are some actual risks of sending people for intervention when they don't actually need intervention. It makes them start to like pathologize their children. And so that's something else to just kind of look out for, because sometimes we usually will say if there's ever counseling as an option, that's always the right answer. But if the kid's really, truly, totally typical and it's typical behavior, don't pick that one. Find something else in the list. Okay. Okay. So this is about a 2-year-old with crying and screaming, tantrums. Every time she doesn't get something that she wants, mom reports that the girl often throws herself on the floor, kicks, thrashes. She asks how you should handle her daughter's behavior. Yeah, so this is like such an obvious question, I think, to me. Hopefully it was to you guys too. That's always the right answer. And they do really love to ask this question. So this is like a gimme. Nobody ever needs to miss this one. A tantrum we ignore, we drag them to a safe place and we be done with it. We're done with it. Why is timeout not appropriate? Yeah, it's just way too long. It's just not, it's not really well age matched. Also, a lot of 2-year-olds can't do timeout. Like they just don't get it yet. It needs to be like 30 seconds for them at that age. So yeah, 10 minutes is just too long. Oh, okay. Yeah, so I have all kinds of great advice from them because I've had to do this myself. So you can, if you've been using timeout at home, you can time out a child on the fly. So I actually tell families who have toddlers to keep a piece of paper, a big bright colored piece of paper in their bag, like in their purse. It's obviously easier for moms than dads, but grab a bag, carry a mom bag with you. And you can actually time out a kid by just putting their timeout spot right on the floor in the middle of the aisle. And you're like, you're in timeout. So that's what PCIT uses, that we send kids over to Dr. Warren. That's a classic PCIT move, is they will do the same 3-minute timeout. It doesn't matter where you are. You pull that paper out, you smack it right there in the middle of the Target aisle. Yeah, and they can time out there, and it really does work. I'll tell you, I had to do it one time to my son, and that was it. And I didn't have a paper. I just told him, you have to, this is the timeout like tile, you sit on that one. So you can time out anywhere. In fact, many kids, if they're socially motivated, it's super embarrassing to be in timeout in the middle of Target and they won't do it again. But it's actually super duper okay that if your kid's really tantruming, you scoop that child up and you take them out of that store. You leave your cart where it is. You tell the lady, you tell the person as you leave, like, I'm so sorry, I left a cart out, my kid's losing their mind. And literally no store has ever gotten mad at anybody for that, because they want your kid out of there too. And so if they're calm enough to time out on the fly, that's like the best, because then they can't escape from what they're doing. So they're shot, like lots of kids will tantrum in the store because they didn't want to go shopping. So if we take them in, they act wild, tantrum, and then we take them out of the store, they just got out of what they escaped. So they will do that behavior again. They will tantrum in the store the next time because it worked to get them out of there. So if you can time out in the store, that's the best. But if you can't, and they're like banging their head on like the linoleum floor of the store or whatever, you just scoop them up, you leave the cart and you go. Yeah, and usually then I'll just tell you to time out them outside if it's cool enough to do so. And then take them back into the store because I'm so mean. But in South Carolina, there's just most of the year you can't do that. It's just too hot for them outside. And so I just tell them to take them home and try again next time. But yeah, time out on the fly. It's a great trick. I have some families who've laminated their colored square. So it's like impervious to damage. That's strong parenting right there. I'm impressed by that. Absolutely.
So you brought up, so I
Mhm.
get stuck.
Mhm.
Take this picture with the picture of banging and then want you to decide if they're on it.
Mhm.
What is
So headbanging, I'm trying to guess how they're doing it in their questions. So headbanging is a common behavior out of frustration for little kids, particularly if they have a speech delay. So if you have a kid with a speech delay, and who is headbanging. Yeah, they're definitely looking to see if you can think about whether that kid has autism or not. But at the core, remember that autism is a disorder of social skills at its core. I don't care about the headbanging. I don't care if the kid can't talk. So you've got to look in that STEM to find the social skill. And if the social skills are appropriate, it's not autism. If the social skills are behind, autism's your answer. So there, you did the right thing by like thinking headbanging and they're not talking. So could this be autism? But then throw out what you know about the headbanging, because nobody cares really. At the core, that's not autism or not. It could be, it could not be. Look for the social skill. There's probably something else embedded in that question. It's either like they can't request something that they need. They can't self-soothe at all. Don't get distracted by hand flapping and other weird repetitive stuff. Even just from the headbanging, we know the repetitive stuff is involved. Look for the social skill. They'll have to give you some. If you remember, the criteria for autism has A symptoms and B symptoms. And the A symptoms are social initiation, nonverbal communication, and reciprocal interaction in relationships. They have to give you one of those three at least to tell you it's autism. They can't just give you the B symptoms of the repetitive stuff. So there's something, there will be an A symptom somewhere. You got to look for it though. That would be my best advice. And then headbanging, as long as they, so in clinical practice, I will just tell you, headbanging never hurts the children. It seems like it should. I had a kid with Ehlers-Danlos. I was sure this kid had a brain bleed. They had a history of headbanging on something hard, and then the kid had what sounded like a postictal period. I swear to you, the kid headbanged, had a seizure. It was terrible. I definitely CT'd and MRI'd that kid's brain, and it was stone cold normal. I mean, it was an impressive story. I watched the kid headbang. If there was ever a kid who had some terrible thing happen, it would have been this kid with like vascular fragility, no bleed. Your cranium is just so incredibly strong. You really just don't see damage. These kids aren't able to like whiplash. You can't get that back damage. So the brain is not shaking around in there like we think it should, like it would for like a motor vehicle accident or even a bike accident. So they'll always try to trick you up on that. They're always going to try to get you guys to like image the headbanger. We don't image the headbanger. There's just nothing there, I promise you. And so they'll try to detour you with a couple neuroimaging things, maybe an EEG in there. They'll try to trick you up on those, but headbanging is, in general, you just like a tantrum. You move them to a soft place and let them bang away. If the parent asks, yeah, no, they don't know. Because really, they're just not going to do damage. They're going to get a bruise. So it's almost always going to be like intervene, try to figure out what's going on, move them to a soft place, those sorts of things. Good question. I haven't come across any headbanging questions. Now I want your headbanging questions so I can add them for next year. How exciting. You get all the headbanging ones. Fantastic. Now I'm gonna have to cook up a good headbanging question for y'all. So here is another 2-year-old. You see a lot of 2-year-olds pop up on the boards. It's an important age for you to figure out if their development is typical or not. Everything kind of emerges at 2 in the developmental world. So here is a 2-year-old daughter who throws her food on the floor. She dumps out containers of toys. She doesn't say seated at mealtime, and she sings loudly in quiet places. She speaks in phrases, can hop, stacks a short tower of blocks. Parents ask for advice in managing her behavior. So first of all, I would stop you right at the beginning and tell me, is the child's development normal or atypical? Normal. So they gave you that sentence at the end to wrap it up, to tell you this kid's neurotypical. So now you can go into your answers knowing this is a neurotypical kid. Yeah, absolutely. So this is a mean because it's a most appropriate answer. And there are a couple in there that would be fine. But the best is that they wanted you to know that this is a neurotypical kid. They're really asking you, does this all sound typical for a 2-year-old? Yeah, it does. So you're exactly right. You're going to talk to them about setting limits and realistic expectations for toddler behavior. So what you find is that because these questions about behavior are buried in the course content under general peds, when you see them, they usually aren't actually a developmental peds question, if that makes sense. So the first thing I'd have you all do is when you hit one of these questions, look at it first and say, are they neurotypical or not? Are they delayed or not? If they're not delayed, it's a gen peds question. You don't have to think about all the wild behavior management junk that you learned in developmental peds. They're asking you a gen peds question. And then when you look at this, you're like, oh, well, yeah, the obvious gen peds answer is to reassure, right? Reassure and show them behavior management. So in all these questions, kind of think that way. If you think this sounds like a developmental kid, they've given me some milestones. First thing is, are they developing typically or not? Because that will help you weed out some of the other things. Because like on this one, behavioral therapy, start an evaluation for ADHD. They're sending you deep into developmental peds with that. Remember, it's a neurotypical 2-year-old, so we wouldn't think about any of those things. And a behavior, let me just mention, behavior system for a token economy. It's just an older tool that's too old for a 2-year-old, just as a plug. It's a great system for an elementary school age child. Too hard for a 2-year-old. Any other questions about this one? Is that kind of helpful advice, this thought of like, see if they're developmentally normal or not, and then that will guide your answers. It'll make it a lot easier. Okay, so here is a 7-year-old girl, behavior problems at school. Academic skills are average. She's impulsive, has difficulty staying on task and remaining quiet when the teacher is talking. When students line up, she pushes to be at the head of the line. At home, her parents have problems getting her to comply with their requests. She needs frequent reminders to sit and do her work. Her grades have declined over the past quarter. Parent and teacher Vanderbilt forms indicate symptoms of inattention and hyperactivity. So the last sentence already told you what? Yeah, she's got ADHD. So they already gave you the diagnosis. So that was nice of them. So then most appropriate next step. Exactly. So if basic behavioral therapy is always right, unless they gave you a med with it, and then that's probably really right. So this was really just there to tease that out. So and they'll always put it last because they're mean. So they're going to try to get you to impulsively answer A or D before you even got to E, and E's the right answer. And they'll almost always stack it that way for whatever reason. Let's see. So question is, why was the correct answer not the behavior is normal and will resolve in time for a 2-year-old throwing food on the ground? Let me go back and I'll answer that real fast. So the truth is that this 2-year-old behavior will not resolve in time if we do nothing. They will get worse. Their behavior will get worse. They will become more defiant, is the typical course. So if you don't set limits on this 2-year-old, there'll be a 5-year-old who throws food on the floor. So that's the reason why that's not the most appropriate response. I hope that helped, whoever asked on wards. But that truly is the reason, is that we need to do some more limit setting than what we're doing. Perfect, you're welcome. Yes.
So if they, for instance, like, we did it, right, but would you always they don't give you that combination? And then just like, what would be your perception?
So I will just tell you that they're not going to ask you that. And the reason is that's actually too controversial. So originally there's this big study called the MTA study, or methylphenidate study. And it showed it was in the 50s, 60s, and it compared these 3 different groups, like typical community management, which was choose your own adventure, like whatever the doc decided to do, doing a methylphenidate trial for ADHD, or doing behavioral therapy by itself, or doing behavioral therapy plus methylphenidate. And the methylphenidate alone group outperformed everybody else. It matched the methylphenidate and behavior group. So it appeared that there was no effect for behavioral therapy, or not as big of an effect as methylphenidate. And a lot of questions in the past were built on that old study. Well, that same research group has actually repeated that study like multiple times since then. and has made a really loud fuss, like in the ADHD world in the last 10 years, because subsequent versions of that study, when they repeated it, the behavioral therapy plus methylphenidate group way outperformed all the other groups. And so unfortunately, like the test kept propagating this idea that behavioral therapy didn't have much effect, you should just do methylphenidate. And now that group has really argued, no, you really should do both. So what it looks like they're probably going to push is that you need to do both, or they're not going to put therapy in there at all, and they're just going to give you a bunch of medications. A good question. Yeah. Sort of. So token economy, they love to add, there's one behavioral tool they're going to mention by name on boards. It's going to be token economy. So it's good that you like, it's good to know what it is, just so you know whether it's the right answer or not. So token economy is like when you were in elementary school and you like got like bucks, you got little pieces of paper and you could like cash them in at the little store. That's a token economy. Yeah, so a little bit more advanced from a sticker chart. And the reason is, so a sticker chart, you just get a sticker at certain intervals that are prepared by somebody else. With a token economy, you have the choice to cash in your dollars whenever you need reinforcement. So if you're having a bad day, you may give 2 of your, ours were Mustang money. You may give 2 of your Mustang money up to get like a Jolly Rancher. But on another day when you're like doing fine, you may keep banking your Mustang money so that then you can buy the paddle ball, like whatever random thing. So it is better reinforcement in a token economy because the person that the token economy is acting on gets to choose when they need reinforcement. So it's like the gold standard is what we say. That's why they use it in so many schools. So it's good for any kind of naughty behavior. Anytime you're trying to motivate somebody to do the right thing, it helps. It's really the reason we're all paid. It's to motivate us to keep coming to work. And then we get to spend it on whatever we want. It's real exciting. Any other questions about this one? We have a few more ADHD questions, so don't worry. This was not the only one. Oh, but we're going to veer off for a moment. This one got out of order. So an infant born at 32 weeks gestation comes in for a 2-month well-child check. Neonatal course was otherwise uncomplicated, and father has concerns about the impact of his prematurity on his long-term development. Of the following, the most appropriate response is? I know, I saw this question reiterated in multiple prep versions too, the same like teaching core concepts. So they really want you guys to know this. So we'll go through them question by question. Answer by answer. So developmental age should be adjusted for prematurity until you're 2. That was just a mean detail. So it's still 2. It's confusing because we follow kids in NICU follow-up clinic till they're 3. So a lot of times people think it's 3, but we only adjust them till 2. The reason being is that we would ideally like them to have caught up by 1, and we're spotting them an extra year till 2. But if they're going to catch up, most will catch up by 12-month mark. Male infants born prematurely typically have better developmental outcomes than female infants. That's just made up. That's never been shown. In my own colloquial, my own experience, I swear the little girls do better. So, but there's no research to that either way. So there may be research in the affirmative to girls. I don't know. Just made up answer. And then healthy preterm infants have an increased risk of mild motor impairment. Well, that one sounds reasonable, right? Language delays are uncommon for infants born at 32 to 36 weeks gestation. Anybody have any thoughts about language delays being uncommon? It's the most common developmental delay coming out of that age group. So an isolated language delay is the most common. So that one's that's opposite. So that one's not correct because the opposite is true. And then there's no increased risk of intellectual disability for infants born at 32 weeks gestation or later. Not that any of you need to know this, but they have a 1.4 times greater risk. I just learned. of intellectual disability. So the right answer is this mild motor impairment. And I'd be honest, if my taking this question, I would have gone through every single response and ruled each one out individually, because this is not like a quick answer kind of go to. But mild motor impairment, that increased risk would be the correct answer. If they had also put on, which is most likely true, and they've given you a language delay, also the language delay is the most common, but sure, a risk of mild motor impairment. Think about it as like they delayed walking would classify under that. So they really wanted you guys to know about these outcomes of these like late preterm kids. They love this topic. No, I looked through many years worth to see if like that was like a high yield topic. It did not appear to be, so I did not rack y'all with that. I think it's just because their delays are so significant that you're going to have to probably send them to NICU follow-up clinic or to a developmental pediatrician or somebody to rule out what is going on with them. I think they're more worried that general pediatricians would miss the late preterm kid who has a mild delay that nobody caught. So they seem really focused on making sure you guys are watching for this. Okay, so here's the other ADHD question that I knew was floating around somewhere. So an 8-year-old boy has attention difficulties in his 3rd grade classroom. He already did psychoeducational testing. He does not have a learning disability. His parents and teachers completed Vanderbilt forms, and he has ADHD. You are considering starting this child on medication to treat his ADHD. Of the following, the most significant historical information that would affect your decision to start treatment with a stimulant is which of the following? So epilepsy in a sister, bipolar in an uncle, motor tic in the patient, an MI in grandpa at 65, or sudden death of his brother while playing basketball. Sudden death, yes. You will be surprised how often when I give this question, I get any of the answers. So this is just that, like this one, it has 2 teaching points. First of all, the stimulants can cause increased heart rate and can cause abnormalities in your EKG if you have an underlying arrhythmia or cardiac issue. But also, this was definitely one of those most significant. So all of these, except for the grandpa's MI, are things that we need to think about for a stimulant. But there's only one that's like you need to investigate before you put this kid on a stimulant, and that would be the brother dying. Ta-da. Does that make sense, everybody? Good times. Okay, so a 7-year-old boy is brought to the ED by his mom. She found him acting unusually at home. He's agitated, screaming there are bugs on him. Physical exam reveals a heart rate of 150, respiratory rate 26, blood pressure 137/89, pupils are 6 millimeters and briskly reactive. Physical exam is otherwise normal. Mom notes that she found him near the family's medication cabinet where meds were stored to treat grandma's hypertension, sister's ADHD, mom's headaches, and brother's seizures. Of the following, the most likely accidental ingestion is? Yeah, remember it's me giving you the question, so it's gonna be one of mine. But if I'm not here, that would still be the right answer. So this question, this kind of looking at stimulant side effects, has actually popped up several times in the reference to ingestion, which I thought was a fun spin on things. So we'll watch for it there. If it had been guanfacine or clonidine, what would you have seen in that kid? Yeah. So super duper sleepy. Yeah, hypotension, bradycardia. I often find that their heart rate slows even before their blood pressure does. The blood pressure holds on there for a hot second and then tanks. Exactly. So this was just a nice, fun way of looking at stimulant side effects. So increased heart rate, increased blood pressure, hallucination, bugs crawling on you. Awesome. So they're not without risks. Okay, so during a health supervision visit, the mom of a 24-month-old boy says her son says a lot of words, has a great memory. When you call his name, he doesn't respond. Like when you, the doctor, call his name, he doesn't respond. And when his mother asks, you want milk? He repeats, you want milk. He then sings a few words from a popular children's song over and over. So you can stop right here and say, is this child developing typically or atypically? Atypically, so perfect. So now you know, okay, this isn't just a Gen Peds 2-year-old question. This one is actually going to be a developmental Peds question. That's kind of your trigger right there. So then we go on to say in his chart, he passed audiology, general developmental screening questionnaire, said he was below the cutoff for communication and personal social development. So speech and social skills were down. So this is building a very nice case for something, right? He also scored an at-risk range on the parent completed autism specific questionnaire. So now you're disappointed because they're going to ask you something else and you were so sure that the answer was autism. So you refer him to a specialist and the next available appointment is in 3 months. What's the most appropriate next step for this kid? Yeah, early intervention. These are always my least favorite, where you're like, I know this one, this kid has autism, and then they ask you something else about it. But this still should be one of the easiest questions that y'all get. And it does pop up most years on the board, something about knowing to send to early intervention while you're waiting on a developmental eval. I would do that first. Yeah, I would. So she asked, like, if they didn't already do audiology, if they didn't say that in the STEM and they gave you that as an option, would you do that? Yes. While you're waiting, would you do that? I would tell you that they probably would not give you early intervention because you should do those 2 things at once. So if audiology was there instead of early intervention, that would be a great answer. They might put them together. I've seen that as well, which then is like a real tip off that that's the right answer, right? When they're doing 2 right things. I think we've rammed that down y'all's throats well enough to send to early intervention. So I don't think we have much more to talk about with that one. All right, so 17-year-old female presents for a sick visit due to chronic headaches, which have been nearly daily for the past 6 months. Pain is throbbing, worse in the middle of the day. She reports occasional nausea, no vomiting. There's no family history of headaches. She's missed 15 days of school this semester. She's struggling to maintain a C average, doesn't like school because she doesn't like anyone there. And her physical exam is including complete neurologic and fundoscopic exam are normal. Of the following, the best next step in management of this teen's headaches is to do what? Yeah, depression screen would be a great idea. I'm gonna go back just so we talk through the other ones. Yeah, so we're not gonna jump right to meds. The headache journal is a great idea, right? It's not referring to neurology because it's headaches and you're a general pediatrician and they want you to try to solve them on your own first. So that refer isn't gonna be the right answer. So it's either the depression screen or the headache journal. I love the headache journal, but they just gave you too much in this STEM to tell you this kid's depressed for you to ignore that and pick the headache journal over the depression screen. Because, and this is the way to kind of think about it, which one is going to kill this kid in the next week? It is not the headaches. It's the depression and potentially suicide. So that's why that is firmly the better answer of the 2, even though they both seem on the surface great answers. Does that make sense? They love sneaky things like that. Because when you're in a rush, you're going to be like, headache journal, that's the right answer, right? So I just warn you all. And they'll try to trick you by leaving some depression suicide screen somewhere. And 15-year-old small child check. He's interviewed alone. Sorry, typo. He's interviewed alone and reports having difficulty getting up in the morning for school. He's eating more than usual. He's gained 25 pounds in the past year. He's gained just 2 inches in height. Since he broke up with his girlfriend 2 months ago, he's not left the house on weekends. He appears fatigued, less focused, and irritable. His grades are falling. Of the following, the most important next step is to... Yes, exactly. They love to throw urine drug screens on these suicidal kids. I've yet to have that be the right answer on any of them. So just always pass over that one because it's just probably not right. That being said, I picked this question because I wanted to talk about school failure. I didn't give you a million questions on school failure because they all sound and look about the same. But school failure ends up having really like 5 diagnoses. So we've beaten depression a bunch. So we know depression's one of them. What other school failure things are there? So a teenager comes in with school failure. The stem of the question is going to tell you what the answer is, or at least what the diagnosis is. What was that? So a learning disability, exactly. So there you're going to look for one test, like one subject being like failing one subject when everything else is great. And they'll give you that. That's the only way for them to tell you it's a learning disability. Okay, so good. Depression is going to look like this question, right? You're going to have all these sad things stacking up. Weight loss, anhedonia, weight gain. What other things can make you have sudden school failure? Like what? Yeah, so abuse is a favorite. I tell the med students, watch out for a stepdad. It's almost always in the stem. If they point out to you that there's a stepdad in the home and it's school failure, that's where they're headed with this question. I don't know why they always pick on that family member, but that's who it's going to be. That's who's in the stem almost every time. They never, if you noticed all these questions, right? Nobody commented on any of these questions about who's in the house and whether the stepdad's in the house. You gotta watch for that. If they tell you that there's some male, not direct relative living in the house, they at least want you to think for a second, could there be abuse happening in this home? And then going forward. Does not mean that females don't abuse children. It's just the way these questions are built. So watch for that. If they highlight a parent's mental illness in the setting of school failure, start thinking either they're trying to tell me this child has the same mental illness, or they're telling me this parent is super stressed out and is not feeding their kid, is neglecting their kid in some way, disciplining too harshly. Okay, so that's another big school failure set, is like abuse, neglect. We talked about learning disability, abuse, neglect, depression. What else? Drug abuse. So there's always a new group of friends. Like if they tell you about a new group of friends, you just start, ever since he started hanging out with Bobby down the street, all this stuff has changed. And that oftentimes also let you find something in the house, which is always fun. Vaping has been a fun one. So you'll find the little vaping thing, or so the idea is that how they write these questions, particularly around school failure, make them quite easy to figure out what they're going after. If you're looking for like, okay, it's going to be school failure is one of these 5 things. The other one's ADHD, which we've talked about a whole bunch. So ADHD, learning disability, abuse, neglect. Inside abuse, neglect, you could also have rape. I've seen some questions about girls, and they had an event where they were raped a month or so ago, and they don't want to go to school, and they're now wearing really baggy clothes, and these all present as school failure. And every single one of these, I will tell you in the answers, it's going to ask you about an ADHD screen or starting an ADHD med. It's going to talk to you about sending for psychoeducational testing. They're going to try to get you guys thinking, oh, this is just school failure, but they're going to give you some other thing to make you think, I need to evaluate in a different direction. Just watch for all those different direction things. Okay, does that make sense? They love them. I can't tell you which one you'll get, but you'll get one of them at least, I guarantee you. Okay, so those were all the questions I have for y'all. Did y'all have any questions for me about either just how they ask these questions, or about any of these kind of wild content specifications? I'll put those back up for y'all so you can see those again. Because I think in general, you guys know the developmental PED stuff, other than the milestones, which are a big pain in everybody's rear end. You guys know this stuff. I think that's just how they present it that is what makes these questions tricky, is that they have presented things subtly sometimes, and so you can easily reading through miss it. So slow yourself down to ask first, is this child typically developing or not? And I think that helps you a ton to know which set of thinking you need to go down. Do you need to go down like well child check gen peds route, or developmental peds route? Because they're going to try to get you to overreact on the well child kids. is kind of their jam. Kind of like the 2-year-old throwing stuff down. Like, do you need to intervene right away? Do you need to intervene a little or not at all? Those are kind of tricky questions. But if you look at it through that first step of, is this child neurotypical? Let me go from there first. That should help. Yeah.
So for development, you know, all different categories, and then they're like, okay, which of these are delayed?
Yes.
And that I always get tripped up on, just because of which of these is his actual age, you know? So
Yes.
you always say go with the oldest. It's explaining whether it's language or whether it's.
Yes. So yeah, if you have like, let's say that they gave you 4 different like a milestone from each of the 4 or 5 domains, depending on whether they're going to count social or not. Look through there, and the oldest thing that child does in that style of question, the oldest thing that they do, that is the age that you're going to compare all the other milestones to in terms of finding the one that is low. Those questions, I'll just tell you, if try to take a stab at it and then move on with your day, because you can get just so bogged down. That's the meanest milestone question. The truth is, at the end of the day, you either memorize those milestones or you didn't. You're not going to figure it out if you don't know them cold. So do not waste time. Waste thinking time on a different question. That's not a good, it's a black hole of time, because you'll sit there and try to evaluate which one it is. And meanwhile, there's another question 4 down that you could figure out and get right if you spent 15 seconds thinking about, and this milestone question is not the one. So if they do one of those, because then they're also going to have on there, which of these milestones is low, or is the child totally typical? So you could get stuck. I could get stuck thinking about that for 10 minutes, and I'm a developmental pediatrician, like second guessing it and thinking, well, actually, maybe they should have done 3 weeks earlier. So take a stab at it and then move on. Yeah, I know I'm not supposed to say things like that, but that's really like, that's test taking strategy. That's the truth of it. There are some questions that are just evil, and that's an evil one, but you will get them. They will be there. Not usually a ton, or if they do, what they're going to be looking at is in terms of prognosis. No, honestly, if you get a question that's that age group, they're going to ask you about NICU management. They're just probably not going to ask you a bunch of prognosis type stuff on that kid. First of all, there's so many factors prognostically. I mean, you guys know from being in, if you got to do NICU follow-up with us, I've got 24 weekers who walk and talk on time and run around and are socially looking great. And then I've got some 32 weekers who had nothing go wrong at all in the NICU with them. And they are struggling in every single, milestone. So it's too open for, yeah, it could go anywhere. They could be good or they could struggle a lot. Language though, that's the first milestone that's going to be delayed for any preterm at any age. Highest risk is language. And then, yeah, any answer where they say a mild delay, like that mild motor delay. You're like, yeah, I mean, that could be right. Yeah, it certainly could be. They could be mildly delayed in anything. They could have said a mild fine motor delay for all we care. It didn't matter which milestone. Any mild delay would have worked in that question, the way that they wrote it. They were trying to trip you up with the language thing and trip you up with a couple other things in that question more than anything else. But yeah, any mild delay from that age group. Any other questions? Okay, and then the second, just the other content, this is a lot of psychiatry type stuff. I didn't do much of the substance abuse, and prescription medication abuse was in there. I don't know, that feels like that's like shared by the ED and us and everybody. So I didn't know if you guys would get some questions from elsewhere there as well. Very good. So with autism, they're not going to ask you too much because we just don't know much. So that's one of the ways to look at it. That's why they love just raking you over the coals with milestones, because we know those, they don't change. They've always been the same. So they love to ask you guys those questions. but autism is going to be much more about recognition. ADHD is going to be about ADHD from top to bottom. So how do you evaluate it? How do you treat it? What do you watch out for with treating? They expect you guys to know ADHD in and out, which is why you get it on multiple rotations. So good times. Welcome.